Hello, my name is Shelby. I go to King University. I'm a nursing student. I will be performing a head-to-toe assessment on you. Could you tell me your first and last name and date of birth?
Zachary Walker, September 1st, 1996.
All right, can you tell me where you are?
At home.
All right, and can you tell me what year it is?
2022.
All right, and do you know who the president is?
Hi.
All right, so patient is alert and oriented ×4. First, we are going to assess the patient's skin, hair, and nails. I would put gloves on for this so I can assess the hair first. We can look for infestations, we can look for lesions. We could also kind of check for any deformities or masses. We want the head to be symmetrical. Hair is brown, no alopecia, no signs of infestation. Hair matches with ethnicity, hair is straight, and then we can assess the skin. So I would do this with the backs of my hands, and we're just feeling for the temperature of the skin. It's warm and dry. There's no lesions or masses noted. While I'm doing that, I can just come down to the hands. While doing this, I can also start to assess the joints. So just going down the hand, we can be assessing the joints. I would be noting any redness, signs of infection, localized swelling, if it's inhibiting movement of the hands. So this arm looks fine as well as this one. So we can now come down to the nails. Nail beds look good. The consistency is good. Coloration is good. We can go ahead and check capillary refills. And we can do this on each finger and on the toes as well. And they're all under 2 seconds. And then we'll come up here and we'll check his skin turgor. Can you sit up straight for me? Perfect. And then no tenting is noted. Next, I'm going to go to the head, face. Can you smile for me? Can you puff out your cheeks? Can you close your eyes? All right. So this is checking trigeminal nerve. Patient is able to do all of this so that cranial nerve is working. I can next palpate the sinuses. I'm just going to, right here, do you have any pain with that?
No.
All right, and then right here, do you have any pain with that?
No.
So that's the maxillary and frontal sinuses. I can next assess the lymph nodes. So I'm going to just apply pressure. Let me know if this hurts at all, okay? All right, so it's preauricular, posterior auricular, occipital, submental, submandibular, posterior cervical. We have the deep cervical chain all through here. Posterior cervical, supraclavicular, and I was not able to palpate any of these sinuses or these lymph nodes, and the patient declines any sensitivities to them. Next, I can have the patient sit up straight, and then can you turn your head towards there? All right, and then no sign of JVD, and then I'm going to have you do that on this side as well, and no signs of JVD, and then I'm going to come from behind the patient, and then I'm just going to slightly move your trachea over. And can you swallow for me? All right, so I could feel the patient swallowing, and then we'll come to the other side. And can you swallow for me? All right, and again, I can feel that. And feeling the trachea, it's midline. There's no masses. So while I'm here, I can actually assess the carotid for any bruise. And I'm going to do that with the bell of my stethoscope. All right, I'm going to have you hold your breath for me. All right, and take a deep breath. And hold your breath again. All right, and no bruise were noted on the carotid artery. And then we are going to check eyes and ears. So first we're going to start with Perla. I'm going to have you look straight at me. All right, pupils are at about a 5. They're equal and round, and now we're going to check to see if they're reactive. All right, and pupils are reactive. And then I'm going to have you look at the TV right there. And then on the count of 3, I'm going to have you look at my pen light, okay? 1, 2, 3. All right. And patient is able to accommodate. This is cranial nerve. This is the trochlear cranial nerve. And then we're going to check your EOMs. This is your extraocular eye movement, so you're just going to follow my pen, okay? All right, no nystagmus noted with that. Next, if I had an otoscope, I would be able to check the inside of the patient's ear. Before we do that, we can check the surrounding part of the ear, note any lesions, any masses, any bruising, any discoloration, and then I could look inside of the ear with the otoscope. I would want to hold it like this so I can study it on the patient's face. We're looking at the ear canal. At this point, I could ask the patient, are you aware if you've had any ear infections as a child?
Not.
Okay, so if we saw scarring in the ear, that would not be consistent with the statement, and then the tympanic membrane should be gray and pearl-like. And then same for the other side. We're going to assess the outside of the ear, then we can assess the inside of the ear. Gray and pearly tympanic membrane is what we want to see. If they have scarring, that's usually indicative of the chronic ear infections as a child. So now I can perform a hearing test. I'm going to have you occlude one side of your ear for me. So do this side for me, please. All right, and I'll stand further behind the patient. And then tell me what you hear.
Cat, window, bed.
All right, perfect. So patient got 3 out of 3, and then occlude this side of the ear. And then I go further behind the patient, but for the presentation, this is as far as I can go. Can you repeat it after me? Were you able to hear those?
No.
All right, so the patient was not able to hear those on that side. That is an abnormal finding. We want 2 out of the 3 on either side. Patient could get 3 out of the 6, so then we would refer the patient for further testing on that. And now we can check nose, mouth, and throat. So first we can inspect the nose. I'm going to have the patient occlude either side of the nose and check patency. So could you occlude one side of your nostril for me and breathe in and out? All right. And were you able to do that on that side?
Yes.
All right, and then the other side. All right, perfect. So patient patient was able to breathe on either side, so nostril patency is good. Now we're going to inspect the nasal cavity. I'm going to have the patient look up for me. All right, and I can just do this with my pen light. And we're noting if there's any deviated septums, which there's not, any polyps, which I do not see. Mucous membranes are moist and pink. Were you having any issues with your nose lately? Any drainage, any discomfort?
No.
All right, perfect. Next, I'm going to assess the mouth. And I'm just going to have the patient smile. Perfect. So I'm assessing the lips, noting any discoloration of the lips. Lips are pink and moist, no cracks noted. And then can you hold your lip out like this for me? All right, so I'm assessing the gums now. And then the inner part of the lip, the gums are pink and moist, no lesions noted. Now, if I had a tongue blade, I could assess the patient's buccal mucosa. I'm just going to have you open it like this for me. All right, no lesions noted, pink and moist. And then can you look up for me and say ah with your tongue out? And you can stop holding that. Perfect. Say ah, tongue out as wide as possible. All right, soft palate is pink and moist. Hard palate is pale and moist. Again, if I had a tongue blade, I could better assess the throat. We're looking at the tonsils. We're going to grade those on a scale of 1 to 4. We're looking, and have you had your tonsils removed?
No.
All right, perfect. Let me try and assess those real quick. Say ah. Keep saying ah for me. Stick your tongue all the way out. All right, so I'm unable to see the tonsils. What we're looking for with the uvula is that it's midline and that it does go up in a straight line. And then the pharynx, we could see if there's any white exudate or if there's any redness or swelling. And the patient was able to say ah. And this is the glossopharyngeal cranial nerve that we'd assess with that. And now I'm going to inspect the respiratory system. So I'm going to have you breathe regular for me. And I can note that the patient is in a tripod position, that they're comfortable. The breaths are effortless. Patient does not seem to be in respiratory distress. I'm going to come behind the patient and inspect the thoracic cage. And I'm going to have you breathe in for me. Take a deep breath. All right, so my hands move symmetrically while doing that, which is a good sign. And then I'm going to percuss the back. So I'm going to have you turn slightly just so I can turn your whole body just a tiny bit for me. Perfect, perfect. So we're going to percuss the back. I'm just getting in a good position to where I could do this. All right, and then we'll assess the CVA tenderness. And does that hurt at all?
No.
Okay, perfect. So if he had CVA tenderness, that would be indicative of a kidney infection, which the patient does not have that tenderness. Now I'm going to assess, we're going to listen to the back while we're back here. Each time I move the stethoscope, just make sure you take one breath in and out and breathe through your mouth. All right. All right. No adventitious lung sound were heard with that. And now we can assess the heart sounds. I'm going to have you sit straight. I'm going to let you face back again here. All right. So, all right. So we're going to assess this ape to man. So, this is aortic. Pulmonic. Erb's point. Tricuspid. And mitral valve. And then I'll do the same, just listening with the valve for bruits, or for heart murmurs. And then this is the aortic, pulmonic, Erb's point, tricuspid, and mitral, and then I'm going to assess the patient's apical pulse. All right, and you would assess that for 1 minute. Okay. And next, after checking the heart, we can assess the lower extremities for any edema. So I'm just going to have you lift your leg right up here for me. All right, so we can visibly see that there are no signs of edema. If there were, we could test it on the pitting scale. No signs of edema, and then I'll check the dorsalis pedis pulse. All right, and then we'll check the posterior tibial pulse. All right, so I can feel the pulses both, so that would infer that the circulation, blood flow is good, going all the way throughout, because we can feel the apical pulse, and then on his feet, we're feeling for the dorsalis and the tibial. All right, and pulses are normal, 2+, and then I can have the patient stand up, and we're going to perform the Romberg's test. So could you stand up for me? All right, and with this test, I'm going to have you close your eyes, and you're just going to stand still for me, okay? With your arms straight down by your side. And then And you can close your eyes. All right, and you can have a seat for me. Patient did not have any issues with maintaining his balance with this test, and now we can assess his gait. So I'm going to have you stand up for me, and then I'm just going to have you walk around this table for me. All right, and you can have a seat right back here. Patient was able to round the corners. Patient did not have to steady himself with any objects or walls. Did you have any difficulty performing that?
No.
All right, so now we're going to do deep tendon reflexes. I don't have a hammer, but what you would do is you'd want to steady, reinforce this. You'd want his legs above the ground so they're not resting on the ground. You'd go about right here, and we want to check those reflexes. And that is graded on a scale of 0 to 4. 0 being absent, 1 and 2 being normal, 1 being you could recheck it and see how that is after the first time. And then palpating the joints again like we did when we were checking the skin, just going all the way down. And we're checking those joints for any redness, inflammation, irritation, any pain. We could also check the Fallon's test by having the patient do this. Do you have any pain with that?
No.
All right, perfect. And then again, that's checking carpal tunnel syndrome. And then we could do the tingle test. Do you have any pain with that or tingles?
No.
All right. Pain or tingles?
No.
All right, perfect. Can you it's circumduction for the arm. Can you do this with your arm for me? All right, and then your other arm. And do you have any difficulty doing that?
No.
All right, and then can you turn your neck for me? And then we had a patient do this as well when we were doing the JVD distension. Can you place your arms both out like this? And then, all right, patient can perform flexion and extension of the arm or the elbows, and then the wrists. All right, and then lay your arms flat. All right, supination and propination. And then I'm going to have the patient stand up. And then you're going to lift your leg up like this. Any pain with that?
No.
All right, and then your other. All right, and you can have a seat. And then I'm going to have you put your legs back up to here. All right, and then I'm going to have you pull your feet towards you. I'm so sorry. Keep them straight and then push them towards you like this. All right, and then like you're pressing on the gas pedal. All right, patient is able to do this. So that's his dorsiflexion and his plantar flexion. And then I'm going to have you lay down flat for me. And the first thing I'm going to do is inspect the abdomen. I'm going to have you keep your arms down, and I'm just going to pull this shirt up a tiny bit. We're inspecting the abdomen contour. And then after inspection, we can also rotate his abdomen. We're going to start at the right lower quadrant, as that is a normal area for bowel sounds. Hearing bowel sounds. If we were not, we'd have to wait a whole 5 minutes before saying there are absent bowel sounds. All right, bowel sounds in the right upper quadrant. Bowel sounds in the left upper quadrant. And bowel sounds in the left lower quadrant. And then you could assess the patient's left bowel movement, and you can then percuss the abdomen, and then you can palpate the abdomen. For a heavier patient, you would need a deep palpation. You're just going to slide circles. Tell me if you feel any tenderness.
No.
Right. Any tenderness?
No.
Any tenderness?
No.
Any tenderness?
No.
All right, if the patient does feel slight discomfort in the lower left quadrant, that can be a normal finding, as that's where the sigmoid colon is. And then you can sit back up for me. Did you have any questions?
No.
All right, perfect. That is the end of my head to toe assessment. Thank you.